Well, good morning, everybody. All feeling bright and perky? I'm going to try my best to be bright and perky. I figure I've got about 30 minutes of bright and perky in me. So, but if I'm snoring later on, you can throw something at me. But anyway, thank you so much to Sarah and Tammy for inviting me to speak. It's really a lot of fun to be here, and I think this is a great topic, and I'm really excited to be able to contribute to it. I think I want to say right from the get-go, however, that there are various kinds of keynote addresses. This is a keynote address. It sounds very heavy, and when you're asked to do a keynote address, you sort of want to present something very complete, substantial, and there's something that has a kind of a final slide that's kind of like a crescendo, and I can do something a little bit like that. You know, I've certainly got lines of research where I can sort of tell you where we've got to, and we've got some preliminary things that we kind of think are true. But actually, today's talk is going to really end with a question. So I just want to put that out there right from the get-go, that really this is more about a new direction, a new idea that we're looking at in our work, and hopefully it's something that we can talk about. I think we've got like a good amount of time for question and discussion at the end, and so hopefully we can have some dialogue about it and see what you think about these ideas. So I want to start off with talking about adolescence, and this is probably well-worn territory for a group of people who are interested in substance use, because of course adolescence is a key onset phase. But I just will mention that I've been involved in a report, a commission report that was just published and launched this week in the Lancet, the British Medical Journal, about adolescence and adolescent health, global adolescent health. And in this report we make an argument that adolescence is a key phase of life for investment in terms of health. And we talk about this idea of a triple benefit of investing in adolescence. The fact that, you know, when you invest in adolescent health, you not only get benefits for the adolescent, hopefully right now, you also get benefits in terms of their trajectory, their lifespan, because of course so many things that determine health across the lifespan are being established during adolescence. And then of course, finally, adolescents are also the parents of the near future. And so that their health and well-being is going to have an impact on the next generation. So it really is important for that reason. And I wanted to just quickly show you some data from the report. This is looking globally at adolescent health. And I just want to show you this nomenclature that we used in the report to talk about three different classifications of countries. One is what we call NCD, the predominant, that is non-communicable disease predominant, so that includes the more developed countries, North America, Australia, Western Europe, Britain, and so forth. And in those countries, the diseases that we're dealing with are more of this non-communicable type, heart disease, cancer, behavioural health issues, and so forth. Then we have a group of countries that we call injury excess countries. So these are countries where young people are experiencing a lot of injury, often due to conflict, armed conflict and other reasons. And then there's also a group of countries called multi-burden countries, which tend to be very undeveloped socioeconomically and have lots and lots of different problems. But what I want to show you is this graph of the burden of disease. So these are telling you about Daly's disability adjusted life years. So it's the burden of these different kinds of diseases in women and girls, or men and boys. This is aged between 14 and 24 in these different countries. And there's a lot of things you can see here. Certainly you can see that in the multi-burden countries there's an excess of infectious diseases, injury, and so forth. We've got the injury excess countries. But really what I want to show you is two things here. First of all, that mental disorders and alcohol and substance use are a fairly persistent component of the burden of disease across all of these international contexts. The other thing I want you to notice is that the burden of disease associated with these problems is not really reducing. Over the period from 1990 to 2013, which this covers, you can see that although we're seeing significant improvements in infectious disease, in injury rates and many of the other health problems we're looking at here, in terms of mental health and substance use, we're not seeing much change. So this is a real challenge for us in our field to find a way to really improve our intervention so that we can have this kind of broader public health impact that we really want to have and that they are having in other areas of medicine. So, so this is just to focus in on this issue of mental health and substance use. And as you can see, this graph represents, the red bars represent the typical age of onset for a range of different important mental health and substance use disorders. And you can see that this period of life that starts curiously right around the time the gonadal phase of puberty, which we often define as the beginning of adolescence, to early adulthood is a key phase of life for a whole range of disorders. Substance use disorders, anxiety disorders, although there obviously is onset earlier for those disorders, mood disorders and schizophrenia. And these are, many of them are disorders that are going to have burden for the individual across the lifespan, even though the beginning is in adolescence. This is a specific graph about depression, which has been the focus of my research for many years. And you can see once again that there's this peak right around the mid-adolescent period in terms of the onset phase of depression. And in terms, once again, to talk about burden of disease, you can see this is once again the disability adjusted life years, and you can see the burden of disease from depression is not only very significant, these are just within the mental health field, but also has that peak during adolescence and early adulthood, and of course the second most burdensome one are the drug use disorders here. So we're really talking about a very significant and burdensome set of disorders. This is my favourite new bit of data about adolescence, which I just came across a few weeks ago. This is about wall punching, right? And this is data on the age of people who come into the ER having broken their hand punching a wall. And once again, you can see that this particular behaviour is not randomly distributed across the lifespan. There is once again a clear peak right around here in the mid-adolescent phase. And so once again, we could look at lots and lots of data. We could look at the violent crime index, we could look at data in terms of the onset of substance use, and we'd see that same pattern over and over and over again. It would get kind of boring. So the challenge, as I said before, is how to enhance the effectiveness of our treatment strategies in mental and behavioural health. And in particular, there are two themes that I've been really focusing on. The first one is early intervention rather than treatment of advanced illness. Now, I'm not going to emphasise that too much today. I could give you a whole another talk about that, and it probably wouldn't be controversial in this room, I wouldn't think. But I do think that when you look at those areas of medicine and public health where there's been really significant changes, it's almost always been associated with early detection, prevention, and early intervention. And so I think that that's a key paradigm if you look at these other areas where we've really made progress. The second one is this idea of precision or personalised medicine. We have treatments very often that work reasonably well for some of the people. What we have a very poor understanding of is what are the powerful, reliable and replicable moderators of treatment effects, so that we can start to match people to treatments more precisely. And in fact, we really are still doing a fairly poor job of that. Most of our treatment selection is done empirically in the clinic. So in other words, we try things and some of them fail and some of them work with an individual, and then we go on from there. And so that's an okay approach, but the question is, can we do better? Now, I'm here to talk to you about a particular moderator that I think might be very important, and that is that that is developmental variation. So in other words, as people grow and change, they develop, and this is already recognised as a potentially significant moderator of treatment. Every person, every clinician who works with children and adolescents will tell you that they, in their clinical practice, match their treatment approach to the developmental phase of the individual that they are seeing. And yet we have very poor empirical basis for doing this. And there's a whole range of reasons for this, but one of them is that we actually use the concept of developmental maturation with very poor precision. In particular, we often use chronological age as a way of estimating this. Now, even the studies that have used chronological age do tend to find effects. So there are meta-analyses of the effects of, say, cognitive behaviour therapy and other studies of cognitive behaviour therapy which have shown that age is a significant moderator, typically finding that older adolescents do better than younger adolescents or children with these approaches. Not surprising, because cognitive behaviour therapy was largely a treatment designed for work with adults, and then it was extended down developmentally, generally with what I would say were fairly trivial adjustments. You know, sometimes it's as simple as just making the rating forms using the different fonts and having more cartoons on them or something like that. You know, so often there's a very shallow kind of adaptation that's done that's not very sensitive to developmental change. This is the worst slide that I'll show you, but it just makes the point again, which is that this is from a meta-analysis done by Eric Stice, a colleague of mine who works up at the Oregon Research Institute, and he was looking at prevention programs for depression. He was looking at all the different characteristics of prevention programs and looking at which of them predicted either the immediate post-test outcome or the follow-up outcome. And what I want you to focus on here is this little box. I'm helping you there with this horrible figure to show you that participant age is one of the key predictors of both the post-test outcome and the follow-up outcome. So once again, we see evidence of this developmental moderation. But as I said, when we use chronological age to estimate development, we're actually using an extremely imprecise tool, and it's especially imprecise during adolescence. I mean, just think back to your own adolescence and the variation in the timing and the tempo of the way people developed, right? There are reasons for this. One is because, of course, we have puberty, which is a very dramatic developmental event, and it happens at very different timing and tempo between individuals. And then you also have adolescent brain development, which I'm going to talk about in some more detail, which also shows significant variation. And people, there's a kind of a strong folk psychology around this. People often talk about adolescents saying, well, he's a very mature kid, he needs to grow up a bit, or something like that, which means that compared to peers, this kid isn't where we expect them to be. But as you can see in the picture with chronological age, you can really get some very dramatic developmental variation or maturational variation. So age is a bad indicator, and especially in adolescence. Now, before I go on further, I want to talk about two key concepts in thinking about the way in which adolescent brain development might moderate treatment response. One is the concept of platforms. So the concept of platforms refers to whether a child's level of social, cognitive and emotional development either constrains or facilitates what they can learn from the intervention. For example, we don't typically teach calculus to 6-year-olds. We teach it to 15-year-olds with varying success, but we do have an understanding that this particular curriculum is that the brain is going to be more developed, and it's going to be more propitious to teach it at this particular phase of development. And so that, in a sense, is a platform. The person has the platform of cognitive skills that then allow them to access what's been offered in the intervention. And in fact, there's been a lot of thinking historically about this concept in developmental and educational psychology. In fact, Vygotsky developed this, who's a very famous developmental psychologist, developed this idea of the zone of proximal development. And the idea here is that we have this, these are the things the learner can do without help. These are the things the learner cannot do. But the zone we want to be in is the zone of proximal development, which is what the learner can do with guidance. And so this is a concept in educational psychology, but we want to be able to apply this same kind of thinking to our intervention science. We want to be able to think, we want to be, in a developmental sense, offering the intervention that occurs in this space where the learner can access what's being offered. Now, the second concept is the concept of plasticity. And the idea is, of course, that there are sensitive periods in development and in brain development, where particular kinds of environmental input will be particularly important for the development of the individual. And so these sorts of ideas have been worked out in great detail, for example, with the development of visual perception. But the question of whether there are particular times of plasticity for social and emotional learning, for learning of behaviour regulation, self-control and things like that, is actually much less clear at the moment. And so, but nevertheless, the idea is that there may be sensitive periods where there's certain kinds of environmental exposures which are going to have much more profound effects across the lifespan because they actually bend the twig in terms of development. They actually change the trajectory. And of course, there's an interaction between the concepts of platforms and plasticity, because what often happens in development, as we understand it, is that there are periods of plasticity, which means that the brain is ready to learn from a particular kind of input, but there's great flexibility. But then after that learning has occurred, often the window of plasticity closes in order that more or less builds a platform. So that those skills, those capacities become part of the repertoire, and then often a new window of plasticity opens of a different type. So understanding this sort of cascading windows of plasticity is, once again, I think a key concept in understanding how to target our interventions at particular sensitive periods. Oh, went the wrong way. Yeah, so this is just a graph from, oh hello, I've had a laser pointer all the time. I could have been pointing away, not walking back and forth. So this is just a figure from a paper, very nice summary of the literature, showing this concept of sensitive periods in brain development across and how it's developmentally staged. Of course, this is all framed in terms of exposure to stress. So there's a very rich literature on exposure to stress and its effect on brain development. A lot more to know too. But of course, what we would really like to know is what are some of the positive exposures, whether they be environmental or whether they be in terms of intervention, that might be also we could leverage in terms of our intervention work. Now, I want to talk for a minute about a paper that just came out by Judy Garber and some of her colleagues in the latest issue of the Annual Review of Clinical Psychology. And it's a really nice paper. I know that Judy's been working on this for a number of years and we've talked about it. It's really one of the first papers to try to take this concept of developmentally targeting and tailoring treatments really seriously. Now, Judy's very much in the area of cognitive behaviour therapy for depression, for mood disorders, and so a lot of her thinking is framed around that, but I think it has general applicability. The other thing to say is that Judy's not really a neuroscientist, and so she hasn't really tried to integrate the neuroscientific perspective very explicitly. But this is what she says we should be doing. First of all, we have to specify what are the skills being taught in the intervention. What are the particular things that we're trying to impart? Then you have to identify the cognitive, social and emotional abilities needing to learn the skills taught in therapy. So that's been in the zone of proximal development. Then you have to describe the normative developmental course of these skills. So you've got to have some sense of what's the normal growth curve here. Then you've got to determine the best way to assess them so that you can assess a kid in terms of the development of these skills. And then you've got to use this information to construct an individualised treatment plan. So in this paper, which I recommend you take a look at if you're interested, they have a number of tables like this where they look at cognitive techniques, for example, in cognitive behaviour therapy, and they identify what specific techniques, and then they identify the specific cognitive, and in other tables, emotional and social developmental skills that are required to really access these techniques. So let's take a very simple one, that's really fundamental for cognitive behaviour therapy, which is the ability to identify thoughts. And that, of course, requires a certain capacity for metacognition, a certain capacity to observe your own thinking. And we know that this kind of capacity develops across the lifespan, and particularly shows strong development during later childhood and throughout adolescence. So the idea that you could start doing cognitive behaviour therapy with a kid and ask them to identify their thinking without them having developed these kinds of skills, you may be really having a tough time there. You may be asking them to do something that's not in that zone proximal development. And you can see that there's a whole range of other skills that are referred to: scientific reasoning, social perspective taking, theory of mind, etc. In fact, if we think about our interventions, this is a partial list at best, but if we think about our interventions, there's a whole range of specific skills that are necessary for most interventions that we do. Metacognition, scientific reasoning, social perspective taking, self-reflection, theory of mind, the capacity to think about what other people are thinking or they're feeling or what they know. Here's the one that might be particularly interested for a group of people who are interested in substance use: temporal discounting. So you're probably very familiar with the concept. This is the way in which we tend to discount the value of things that happen in the future. So if I offer you $1 today or $1.10 next week, you'll probably take the $1 today, because you're discounting that, even though the future outcomes. But if I offered you $10 next week, you'd probably take the $10 next week. So there's this temporal discounting function, and it's well known that people who suffer from substance use disorders often discount future outcomes more powerfully than do others. Interesting from the point of view of today's discussion, temporal discounting also shows a clear developmental trajectory, and in fact it's an interesting skill because it's one that really changes in mid to late adolescence. So it really does show a lot of developmental change around 16 and after. So it's an interesting skill. But once again, if we're doing an intervention which requires the person to weigh up the value of using a drug now versus the long-term effects, perhaps aversive effects of using that drug, and we're asking them to make that calculus in order to change their behavioural decision making, it may be that their level of development with respect to this skill is going to really be a key moderator of the extent to which they can really access that intervention. So, if we're not going to use chronological age, what other tools do we have from developmental neuroscience that we can look at? Well, one is puberty, and puberty is a good one to look at because it's something we've got a very well-defined system of assessing it, especially in the later phases of puberty where there's lots of morphological changes and you can do Tanner staging and so forth. And I've got a lot to say about puberty. We've done a lot of research on puberty over the years, but I'm not going to emphasise it today, mainly because of time and because I want to talk more about the imaging work. But the limitations of puberty are, first of all, it only covers the earlier phase of adolescence. Most adolescents are at what we call Tanner 5, which is the most advanced stage of pubertal development. By the age of, well, it can be as low as 14, 15, 16, you'll have most kids at Tanner 5. And so obviously for substance use problems, we're often very interested in that later adolescent group and the early adulthood group, which is where the prevalence is very high. Secondly, puberty is not particularly related to the most relevant phenotypic features. In other words, these things here, these cognitive and social kind of skills that we're talking about here, some of them are related to puberty, but some of them aren't. Puberty is thought of as largely altering things like reward sensitivity, but not being so directly involved in changes in things like, for example, temporal discounting, metacognition, scientific reasoning, and so forth. So another set of options, and this is what I want to focus on for the balance of my time, is brain development. Brain development is a good possibility because it shows continuous plasticity over the first 2 to 3 decades of life. So we know there's lots of things happening in the brain. It's logically related to the relevant phenotype, so all of those skills that I talked about before, we do have some degree of neuropsychological understanding of the basis of those skills. But the question is, how do you quantify brain development? Is there any aspect of brain development that we could put onto a growth curve, kind of like paediatricians have, where they look at the growth curves for height and weight and so forth, and they can make decisions like this child is showing failure to thrive, for example, or based on these kinds of growth curves. Are there any indices of brain development we have at the moment that are promising in this regard? And I'm going to suggest to you we have 2 at the moment. One is reductions in cortical volume, and the second one is developmental changes in brain connectivity. So let's talk about those. So this is a figure that tries to summarise a lot of the different neurodevelopmental processes that are occurring, particularly in terms of neuroanatomy. and it covers the prenatal period and the postnatal period up to early adulthood. And you can see that there's a whole range of things that we believe are going on. Synaptogenesis, synaptic elimination, axon growth and axon elimination, myelination that are occurring across the lifespan. The important thing for those of us who are interested in neuroimaging is that all these red things are actually things that we can see in the scanner. And we think that these things are related to these things, but often we don't know it that well. So it's an important caveat. So for example, when we see in structural MRI, the grey matter volume and thickness increases in early life and then decreases across adolescence, or that there's increasing white matter volume, or we see, changes in DTI and so forth, we assume that this has got something to do with competitive elimination of synapses, for example, or elimination of axons. But often we don't have a clear understanding of the microanatomical processes that are driving these changes. So let's look at structural brain development. As you can see from this rather busy figure, if you scan over it quickly, you can see that there are two effects that are quite strong. One of them is this reduction in the volume of the cerebral cortex, and the other one is this increase in cerebral white matter. And in fact, just to focus on the first one, this turns out to be one of the most highly replicated and replicable effects in developmental neuroscience, human neuroimaging of developmental neuroscience. There's lots of developmental neuroscience. So this is just an example of a whole range of studies that have shown this effect of this reduction in cortical volume across development, and particularly in the second decade of life. Okay? And of course it was originally described by Jay Geed and his colleagues in some very influential papers based on the NIH database that they have. However, as you'll notice, a lot of these findings are based on sort of cohort sequential studies where you have, this is one kid, we've got a data point there and a data point there, we've got another kid with a data point there and a data point there, and so they're not truly within subjects longitudinal. And so we developed this growth curve based on this sort of estimation from a whole bunch of data from a whole bunch of different individuals, each of whom are contributing to different parts of the data picture in a developmental sense. So recently, just this year, we've published a paper in human brain mapping with what we believe is the first three-wave within subject analysis of the development of brain structure across adolescence. So this is a group of kids who we scanned 3 times when they were 12, when they were 16, and then again when they were about 18. And it's strictly within subject's design. And so, and then we also broke it up into looking at surface area, volume, and thickness of the cortex. Now, surface area, and I should point out that the bluish colours mean an increase, and the yellow and red colours mean a decrease in the measure. So as you can see, for surface area, it's largely increasing, which is not surprising because the brain's getting bigger, you're getting a larger brain, whole volume, right? So the surface area is increasing. The thickness, however, as you can see, there's a lot of thinning going on here. There's a lot of yellow and red showing that the cortex is thin, especially these medial sections of the cortex and the lateral, dorsolateral prefrontal cortex, and so forth. And so that's really quite powerful. Interestingly, we do see some areas of the brain, particularly the temporal lobe here, which seem to be showing cortical thickening. And that hasn't been demonstrated before, so we'll have to see if that replicates, or that may have something to do with our within-subject design being a little bit different. But we certainly see, in terms of a lot of the regions that we're very interested in terms of emotional behavioural regulation and social behaviour and so forth like that, we do see this thinning pattern. Now, of course, the question is, does this actually have anything to do with anything behavioural? You know, you've got these changes in the structure of the brain. Is there any behavioural correlates of this? And the interesting thing about this particular line of research is that for a long time, nobody even bothered to look because it was such a great story. You know, we had this thinning of the cortex, and at the same time, we sort of thought we knew what was happening with adolescence, and we said, well, that must be the cause. But there was very few studies where they actually looked at it within the one data set. So we've started to do that with our data sets. And we certainly do see some correlations with behavioural signatures. For example, this is change in the left anterior cingulate cortex and the left ventral lateral PFC. And you can see that there's a correlation with change in a rating, the self-rating of aggressive behaviour. So that's change correlating with change, which is not too bad because that's kind of hard to get. You lose a lot of method variance advantages and things like that. Not that there are anything when you get any of those when you're correlating questionnaire with brain structure. Once again, we see changes in self-rated effortful control and changes in the left anterior cingulate cortex. Finally, in another paper that we published a few years ago, this was the changes in Stroop interference score from the Stroop test showing cognitive control. Once again, correlating with the left anterior cingulate cortex, which seems to be a really one of those reliable structures that correlates a lot with these behavioural readouts of the brain development. So we do see some evidence for these particular changes in the brain correlating with the kinds of phenotypic features that we would think might be important moderators of people's ability to access and benefit from interventions. So let's talk about brain function for a second. So, of course, for many years now, the popular approach to looking at brain function has been doing fMRI activation tasks. But when looking at developmental questions, these tasks have some inherent limitations, some problems. First of all, some of these tasks, some might say many of them, have poor reliability. And that becomes a problem when we're doing retests within an individual in a longitudinal design. And the second thing is that the affective and cognitive salience of activation stimuli changes drastically across development. So once again, let's think we're doing a study of reward sensitivity and you've got a 12-year-old and a 15-year-old and a 20-year-old. Now obviously the thing that a 12-year-old is going to find rewarding, even if you're just using money, but if you're using pictorial stimuli or anything else, that's going to change dramatically across development. So then you've got this problem. You know, do we show them the, I don't know, One Direction or whoever it is, Justin Bieber, that the 12-year-old likes? We show that to the 20-year-old and they've got a completely different reaction. It's no longer a rewarding stimuli. So we've got this problem, and then of course if you don't change the stimuli, then they become developmentally inappropriate. If you do change the stimuli, then you've got this whole scaling problem. You don't know if you've really shown them the same thing. So personally, I'm a bit more interested at the moment in using some of these task-free techniques, in particular resting state functional connectivity. It's task-free, and so it increases the generalizability across development. It doesn't have practice effects, which is another cool thing if you're going to do the same thing with people repeatedly. And it's got very good, relative especially to activation tasks, test-retest reliability. So, and this is really just a... What time do I need to finish, Sarah? Pardon? 5 minutes. Okay. Hey? We'll give you, okay, well I'll move ahead quickly. So I want to tell you quickly about a study that we did, it was published last year in Psychological Medicine, where we looked at resting state connectivity between the amygdala and the subgenual anterior cingulate cortex, which are two structures that are important components of this medial prefrontal network that is thought to underlie negative affectivity. And we did it longitudinally in a group of adolescents between 16 and 18 years old, so within subjects design, and we were particularly interested in the effect of the onset of depressive disorder. So the first thing to say is that we did see correlations. We saw, the first time we saw correlations between the connectivity between these two structures, functional connectivity, and the baseline negative affect. Interestingly, we also saw a correlation between the change in negative affect and the change in connectivity. So if a kid was higher on negative affect at the follow-up, then their connectivity also tended to increase over that time. But the really stunning thing for us was also this. Some of these kids had the onset of a major depressive disorder. We were interviewing them with the case heads interview at each time point. And this is the group who did not have an onset of a major depressive disorder, and this is the group who had their first onset. They were all non-depressed at time 1. And interestingly, they were all not in episode at time 2. So nobody was in an episode of depression at time 2, and yet for this group who've had the episode, we see this significant increase in the connectivity between these two structures, which we know are associated with negative affect. And you also, this effect is robust if you control for individual differences in negative affectivity. So it is actually an effect that seems to be, as far as we can find in our data, largely about the onset of a case level depression. Now, this is that's a nice study of just 2 regions in the brain, but as many of you will know, things are moving much more that we can look at the whole brain, and we can use some of these network approaches to really understand the patterns of network connectivity, both structurally and functionally, as the brain grows. And because I'm running short of time, I'll be very quick about this. Basically, there is a whole range of literature now that shows, both in terms of brain structure and in terms of brain function, that there is a pattern of change in the connectivity that we see across development. And basically, it's a pattern where you see a shift from local connectivity, so where regions that are very anatomically close to each other are highly connected, to a pattern of more distal connectivity. And that's an interesting pattern because it makes a lot of developmental sense, that there would be this shift from more local connectivity to the brain becoming more integrated and to having more connectivity across different structures. It also makes sense of what we know about, you remember we've talked about before about the increase in white matter, the increase in myelination. Well, what's the myelin doing? It's helping the distal parts of the brain, the long axons in the middle of the brain. It's putting these fatty sheaths around them, which insulates them and allows them to propagate action potentials over a much longer anatomical space. And there's a series of techniques associated with graph theory that have been used, I think, with some effect to describe these patterns in the whole brain. Now, and graph theory is basically, many of you will be familiar with it, I'm sure, but for those who are less familiar, it basically describes these patterns of either anatomical connectivity or functional covariance by looking at various nodes and then looking at the connections between the nodes, the strengths of the connections between those. And the nodes are often determined a priori according to some atlas, and then you look at these patterns of covariation, either to do with activity or to do with size or to do with a tract in DTI or something like that. Now, for the paper I'm about to talk about, I want to introduce you to this concept of hubs. So hubs are nodes that are highly connected, and hubs also tend to preferentially connect to each other. And so that is called the rich club. So the hubs are thought to have rich connections, and then when those with rich connections preferentially connect to each other, then you get this so-called rich club connectivity. So we published a paper last year in Journal of Neuroscience looking at the question of whether we could see developmental changes in this hub connectivity in late adolescence. Now, this is an interesting question from a neurodevelopmental point of view, because one of the key theories is that these kinds of, the hub structure of the brain is largely determined very early in life, and it doesn't change much after that. And that what is happening later in life, this is a change in the peripheral and feeder connections to those hubs, but the hub architecture is largely set. But we were interested in seeing if some of this hub architecture was actually changing during later adolescence. And so we have a group of kids, once again 2 phases, we followed them from 15 to about 18 or 19. There was roughly 2 years between them. And what we found was a really interesting pattern. First of all, we found that only a small number of connections demonstrated either increased or decreased structural connectivity with development. It's a very small number that are showing this developmental pattern. But the connections that did change were actually linked to 93 and 90% of the brain. So they're hubs. They're the important ones that are really. And hub regions showed this distinct tendency to be highly connected with each other that we described before, this rich club organisation. So hubs like to connect with other hubs. And the connectivity between hubs was disproportionately influenced by development. such that connectivity between subcortical hubs decreased over time, and frontal subcortical and frontal parietal hub connectivity increased over time. And I'll just show you that. There's a very confusing picture. Basically, this is describing all the patterns of connectivity. This is just describing what we call peripheral connections, that is non-hub connections connecting to other non-hub connections. These are feeders, which is non-hubs to hubs, and these are hub-hub connections. And what I want to do is focus in on the last one and show you this figure here. What's below the diagonal shows you the things that decreased across development. What's above the diagonal shows you the things that increased across development. Frontal, parietal, temporal, occipital, subcortical. So what you can see here is that the things that increased across development were disproportionately, doing that all the time, subcortical to frontal. And the things that decreased were disproportionately subcortical to subcortical. So I guess what's really interesting about this to me is that we're seeing, development, first of all, occurring at a very late stage of development. Secondly, it's occurring in a very specific way. It's really affecting these hubs, something that had been thought previously to be largely determined much earlier in development. And once again, just emphasises the important plasticity that's occurring in the brain, and it's occurring in a phase of life where there are very important neuropsychological functions emerging developmentally, like, for example, temporal discounting. Now, I can't tell you that this is the basis of temporal discounting. I don't know that. But it could be, and it's certainly worth looking at what are the phenotypic characteristics that correlate with this kind of change. Oh, and this is just another complex picture that shows the same thing. Subcortical, frontal, parietal, temporal, occipital. These are the things that decreased over development. These are the things that increased. What I want you to see is those red lines are the hub-hub connections, and see, look at all these subcortical to subcortical connections reducing, also subcortical to parietal reducing, subcortical to frontal increasing. So it's really just another way of visualising the same set of effects. Now, the theory in brain development is that structural connectivity increases and is therefore facilitative or permissive of functional connectivity increasing. And I won't, once again, go on about this too much, but there is also similar patterns that have been shown in functional connectivity data. And this is a well-known paper by Dosenbach and colleagues. It was published a number of years ago. And the thing that really got we developmentalists excited about that is that, look, looks like a growth curve, right? Looks like the other kinds of growth curves that we see in development. And they did this based on what they call the Functional Connectivity Maturation Index. So it was an index that they created from the data, and basically what it was quantifying was this effect. The green lines are the things that increased with development. The orange lines are the things that decreased. As you can see, sorry, got that backwards. Green decreased, orange increased. As you can see, the orange straws tend to be very long. The green straws tend to be short. So that's what we're seeing. We're seeing that shift from local connectivity to global connectivity. And that's the underlying developmental principle. So this leaves us with some big questions. Can we establish normative growth curves with percentiles for indices of brain maturation, like the ones that paediatricians use? What are the microanatomical and genetic determinants of this change in brain structure? These things that we see in the scanner, and we presume that we understand what's happening at the more cellular level. Often we don't. Are there sensitive periods for the influence of environmental exposures on brain development? Something I haven't talked about today is we've published a couple of papers, I think 3 now, showing that family environments influence patterns of brain development across adolescence. So there is some evidence of environmental sensitivity there. Are there neurodevelopmental markers of an organism's capacity to learn from environmental experience? What are these cognitive phenotypes that are associated with these? That's the platforms. And critically, can this information be used to developmentally target early intervention and prevention efforts to enhance health and well-being? Now, a caveat. Some people say that, I think the historians say that Afghanistan is the graveyard of empires, right? And some might say translation is the graveyard of neuroscience, because we want to translate our stuff. We're really sure that it's useful, but actually we've got to admit the track record so far is not great. And so, and especially for showing, you know, actual incremental validity, incremental predictiveness from our neuroscience measures over and above behavioural measures is still a big challenge. If you look at biological psychiatry, the theme of the meeting that's going to be here over the next few days is really still no application of neuroimaging or genetics that helps you to make a diagnosis or predict treatment with reliability, despite much research on this topic. There's another area that's developing educational neuroscience. Once again, there's many people who are expressing scepticism about what has been achieved so far. So we do need to be very humble about the challenge of this task. It's one where many have tried and failed to make a real contribution. Nevertheless, we're scientists. We like hard problems. We want to make a difference. So we're not going to stop trying. So here are the conclusions. Current data and clinical experience suggest that development is a strong moderator of intervention effects. We've got data for it. All working clinicians who work with kids and adolescents will say it's their profound clinical wisdom that this is true. However, we currently have very poor and imprecise measures for quantifying development in ways that allow precise characterisation of the critical platforms and the periods of plasticity that will maximise the learning associated with intervention effects. So a critical next step is to characterise developmental change in intervention-relevant platforms and plasticity at multiple levels: neural, behavioural, social, emotional, etc. And to identify clinically useful markers of maturation that could be integrated into studies of biological and psychological and environmental interventions. Oh, and here's, you know, for the empirical work that I showed, of course, lots and lots of people contribute to it, which I'm probably the least important. In particular, I want to emphasise Simon Baker, Nandi Vijay Kumar and Chris Davey, who are the lead authors on the empirical papers that I told you about. And thank you.